Hello and welcome to the Washington AHEC podcast. My name is Jordan Johnson. I am the Senior Coordinator for the Southwest Washington Area Health Education Center. Today I am joined by Gretchen Aguilar, who is going to talk with us today about rural health and critical access care. Gretchen, welcome to the podcast.
Oh, thank you very much for having me.
Yeah. I already said your name, but if you could just introduce yourself real briefly, tell us your current role and previous roles that led you to where you are today.
So again, my name is Gretchen Aguilar. I became a nurse in 2003, so 22 years ago. I live in rural medicine. I've lived in rural medicine my whole entire career. Um, Started as a med surg nurse, charge nurse, ER nurse, ICU nurse. I then became CNO in 2011 at a small rural hospital as an RN. And I decided at that time that people who are in the CNO roles really should have a higher certification. So I went back and got my master's in healthcare and leadership.
Okay.
And then in 2020, I got a wild hair and said I wanted to go start practicing for my nurse practitioner. So I went through Gonzaga and in 2023 graduated from Gonzaga with my nurse practitioner. Um, in addition to all of that, I resigned as CNO and became a nursing instructor at Wenatchee Valley College.
Sounds like you have lots of experience, lots of time. You've held multiple hats, held multiple roles. So just to get us started, AHEC in general, especially AHEC scholars, we really like to focus on helping students, like trying to encourage them to get into rural healthcare when they complete the program, or working with rural, urban underserved communities, kind of that critical access care. So when we're thinking about rural health and critical access care, how would you define those two concepts, those two terms?
Rural health, to me, is this very large mass of land that is populated, but not by a great amount of patients or residents. And so there's a lot of area for people to have to travel to go to any medical type care. Um, so we have problems with health access. Don't have a lot. Our closest health access would be to Wenatchee, Confluence Health of Wenatchee, or Spokane, or to Seattle, which are between an hour and a half to 3.5 hours away. Critical access hospitals are these little hospitals that pop up inside of rural communities. They're usually about 30 to 35 miles away from each other, and they help provide access to the underserved patients of those communities. They have no more than 25 beds for any type of inpatient, and any inpatient that we get can only stay an average of about 96 hours. Because if they need to be have longer than 96 hours, they really need to be transferred to a higher level of care. So we do a lot of underserved.
I was not aware that critical access, the 25 beds limit as well as 96 hours. Like I knew there's kind of some rules about length of stay and what kind of level of care is provided, but I wasn't quite sure. Is that like a hard line on those two things, or is that like just a general trying to keep uh, the stress and load on the staff as low as minimal as possible?
It is a definite, there's definite language in CMS that's what we're supposed to try
Gotcha.
to
Okay.
attain. Now, some patients will only have maybe one day or 18 hours, whereas somebody else may stay for upwards of 5 days. And it's the average. Because if those patients need that length of care, they probably should be in somewhere that has a higher or a tertiary care center.
Gotcha. Okay. Oh, that's good to know. I was not aware of that. Um, So then, just to clarify also, when we're talking about rural, you're located in the greater OMAC area, is that
That is
correct?
that's correct.
And so for most, I know this is the Washington AHEC podcast, but it's still surprising how sometimes students don't know if they're from the west side, especially. OMAC is a little city, I don't know, like fewer than 10,000 population,
I believe so,
something
yes.
like that. North central Washington, pretty close, you're heading up towards the Canadian border. So when we're talking about rural, OMAC definitely qualifies as rural. There's definitely a component to that there.
I,
So,
I believe that we are the largest county in Washington State, and I think total is about 41,000 it is our population.
gotcha. Okay. Largest by landmass, you mean?
Correct.
Correct. Yeah. Okay.
Correct.
Maybe we can start with like that 10,000 foot overview by just your personal experience. Why do you love working in rural medicine, or what motivates you to continue to work in that community? Because I'm sure there's challenges unique to it that you wouldn't face in other situations.
That is correct. Um, so I was born in Omak. I've never lived anywhere else but Okanagan County. I have seen many challenges of patients in my differing roles that they need assistance in finding healthcare that is equitable for them. So I get up every day and I go out and find those things that I can help to make my community that much better. Being in rural medicine, I absolutely love it. The greatest piece of rural medicine is that you can be cross-trained anywhere. That's why I've
Mm.
worn so many different hats. Um, so what I call is jack of all trades.
Mm.
But there's also a negative to that. You are expected to do all of those things as well. So sometimes you get pulled in very many different areas. I was a CNO of one of the local hospitals, and my roles, if a nurse called in sick, because our staffing was so low that if one person called in and they couldn't find a replacement, I would be the one that was called. Um, so I could be the CNO this morning and then tonight come back in and work as charge.
Mm.
I was also the OR supervisor. I worked in the recovery room. I worked as a circulator when we had surgeries. I was the employee health nurse starting during COVID, and that was rough. Um, so you've got to have a vast knowledge. But the problem was in 2021, as I got burnt out, and I had already started my journey to be a nurse practitioner, but I knew that I couldn't stay where I was anymore for my own well-being. So thus I'm here at Wenatchee Valley College.
All right. Yeah, kind of take a step back and not be quite so working quite so intensely. It's funny you mentioned that about growing up in rural areas. Like I'm from Wenatchee, and I know that pull to like stay in those home communities is really strong for a lot of people, and that is one of the main attractions to it. Is you know your neighbors, you know your community really well, you know your colleagues. So again, for like those of us who are on the west side, it's kind of hard to think about. Well, why would you want to live in Omak? Well, of course, there are plenty of reasons to do so. And then, of course, those challenges, like you're mentioning about being forced to wear multiple hats just because somebody who needs to step up and do the work. So if you're available, if you're competent, and then it often falls to you to do that. So again, like rural health, or even this like concept of rural kind of as a broad term. Like I might consider Wenatchee rural for somebody from Wenatchee or from Seattle, but Wenatchee is really not considered rural. Is there a lot of diversity even within those rural environments?
Um, I would say yes, there's a great diversity. In the upper north region of Okanagan County, we have a lot of people that live off grid, don't have health care.
Mhm.
To get up to them, if they had to call EMS, sometimes requires some innovation. You get down into the OMAC area, we live right on the Colville Reservation. So we have a lot of our American natives right here. They have a different type of insurance, which could be Indian Health Services. And then if you go towards the Brewster location, it's highly agricultural. And so we have a lot of Hispanics or H2A workers that come in from Jamaica that help with harvest season. So every community absolutely looks different.
Mhm. So we've talked about some challenges you mentioned in your own personal experience. Of course, we could extrapolate that to several other rural situations. So what are some innovations that are going on in rural healthcare? Like what are some positive things that are making access to healthcare better for people in these rural communities? Why would we want to encourage health students to eventually work in rural health? What are some of the exciting things that are coming up?
So what I think is it's highly rewarding because you get to see the same patients multiple times. You get to know your community. Some of the innovations that they have in the hospitals, they have a telestroke. It's a telestroke cart where you have a patient who comes in looking like stroke type symptoms. You can use the telecart to contact a neurologist in Spokane who can actually see the patients through a screen, and the nurse and or the provider use the stethoscope, and that provider can actually hear the person's heartbeat. It's quite amazing the things that we've come up with in order to serve our rural and underserved communities.
Wow,
uh,
that's really that's pretty
but
cool. Like we hear these examples of doctors being able to view patients through long distance, and then if you're working in that facility and you're able to help connect patients to those things, and that, yeah, like you're saying, yeah, that's really rewarding when you're seeing people getting the access to the care that they need without even having to leave their home communities.
that's correct.
Yeah,
It's really nice.
very cool. Well, so you mentioned yourself having to have wear many hats in the roles that you've had, um, and we've talked about the challenges of shortage of staff. So, what are some examples of cross collaboration across disciplines that maybe somebody working in rural medicine wouldn't have to do, where they're working in a more urban setting?
um, so these hospitals, again, very small. There's two of us that don't have respiratory therapists at all full time. So nurses have to take on that role, learning how to do BiPAP machines. They have to learn how to do all the med nebs. They learn how to do all the EKGs. Lab is not always 24 hours, so we are actually the phlebotomist at the same time. If our discharge planner is out for a week or on vacation, we become the discharge planner as well. And we work very closely with our finance group in these organizations to make sure that we have the patients in the right category or right status when they are in the hospital. And then we make sure that they are uh, discharged to a safe environment. So there's a lot of collaboration amongst all the departments of the hospital.
Okay. Is that something like you receive specific training for that, or that's kind of you just have to learn it as you go?
You learn it as you go.
And
One of the clinics I did my practicums at for my nurse practitioner, the lab, if they have someone that's they're really busy, the radiology folk have also learned how to do phlebotomy, or they've been trained to do phlebotomy
sure.
and have a phlebotomy license. So you have someone, you may get your x-ray from this person and then go to lab, and that may be the same
Oh.
person that does your lab draw. Super interesting.
Oh, that's really cool. Because those are two specific, like rad tech is one its own thing, and then I know a lot of medical assistants do phlebotomy. They can also take some additional training and get that phlebotomy.
Exactly.
Okay. Wow. So if you really are looking for an exciting work environment, then rural health is maybe where it's at.
Oh, absolutely. Absolutely.
So then maybe one of the specific challenges would be funding for rural hospitals. So how do they get their money? Is there a shortage of money that might not face an urban center?
So like I had indicated about our demographics, we have a lot of Medicaid that is being used to to fund us, and we also get Medicare money. And sometimes we have undocumented um, patients that come in. They come up through these programs, this H2A program, to come up to our community to pick apples. They get hurt. Um, Not always is it on the job. So L&I doesn't cover all of that. So they have some emergency funding that could help assist that patient with their bills.
Gotcha.
Um, the hospitals also all offer financial assistance if needed, and they can do what's called a charity care. Patients based upon their salaries or their income, they can get a 50%, 25%, 100% write off of their bills based upon how much they make.
Okay, I've actually been recipient of that myself when I was 18, fresh out of high school, my first job. I didn't have insurance at the time and went to a clinic and they took my income and they said, "Yeah, we can help you out with that." So I've personally benefited from that. So it's good to know that that's an option available to people.
the funding that we were talking about in here is there was a time
Hmm.
that all three of these these rural hospitals were on what's called registered warrants, and the
Hmm.
county actually helped us pay our bills and our salary, and it was just this extra funding that really helped us during temporary cash shortages.
Gotcha.
None of us are on warrants anymore.
Oh, okay.
So it was a community. We were publicly owned,
Hmm.
and so that was an interesting thing that we did was called registered warrants.
Okay. So does that mean it's like self-sufficient now because of how, wow, that's really cool.
Yeah. So there was a time that the county says, okay, first you're going to be capped at 2 millions of registered warrants. We couldn't go over 2 million. And then it was in a couple of years they said, okay, we need to start weaning you off, and you guys need to be figure out how to be self-sufficient. And now none of the hospitals are on registered warrants. We just
Oh.
it got us through this really tough time
Hmm.
from about 2010 to about 2017.
Gotcha.
Maybe
Okay.
even maybe a little bit earlier. 2000, it was about 2007.
Okay. And so especially now, like you're mentioning, being able to offer like scholarships to patients who have financial need, like it's really, really impressive that you're able to do that without having that cash flow coming in.
Exactly.
Wow. Okay. I think it's just kind of well known that like staffing issues might be one of the big challenges that is faced in rural communities and rural medicine. So do travelers, like I know travel nursing is really popular. What role do traveling healthcare providers play in rural medicine?
They have multiple different travelers that come in, can do radiology, they can do lab, they can do nursing, they can do CNA work. The only issue is the financial constraints that happens when you have travelers there. Um, During COVID, we had to use sometimes travelers, oftentimes, and they were in a month we were paying over $160,000 for traveler wages.
Yeah.
Um, we do get some of that money back on the cost reports through Medicare at the end of the year. However, that is money outflowing every single month that you may not always have. Travelers are absolutely amazing. They are the help that you need when you don't have enough staff. There are some drawbacks. They're not vested in the community as everybody else that is working for their community. So there's a little bit of disconnect from patient just interactions. Um, and every one of the hospitals here are really trying or striving to have less travelers and have more local people working in our environments. Thus, we have Wenatchee Valley College, and in since I've been here in 2022, we graduated 13 from just Wenatchee Valley College OMAC in 2022. 2023, we had, I think, 14, and every single one of those were from Okanogan County, which has not always been uh, it's not always been that way. Usually it's from people that come from maybe Seattle area or Idaho area, and they come to get that RN license and then go back to their community. So it's been really amazing that we have had such a great influx of Okanogan County residents who want to become nurses.
Yeah, that's really great. And then the Wenatchee Valley College has been able to step up and provide that training for those students. I've known a couple people who've done like travel nursing over the years, and what I remember is they would work or they would rest up from working, or the little bit of other time outside of those two things was like playing tourist and getting to see the local area. So like you're saying, they're not really vested in that local community. Well, that's cool. Well, so that's one challenge would be staffing. What are some other big challenges, big barriers to care in rural health?
Transportation. Um, we have a local link transit, Trango, but it's on limited hours.
Mm.
And trying to get patients to and from their appointments. There's other options called people to people, and they can take these patients who are Medicaid and take them to their appointments in Spokane, Seattle. Got to make appointments for those. We have right now it seems to be a high substance use, a lot of overdoses of fentanyl, which I think is worldwide, but in our little community, it just seems like it's a lot. Um, Housing, we do have problems with housing here. We don't have a lot of places for people to live, to rent, to buy. We have a lot of mental health crises. We have one local behavioral health, but again, they're limited on how much they can help because they're also in rural and their staffing is little. But it is it does make for complications when patients come to the emergency room who need mental health services, and there's no beds
Mm,
outside for us to transport these patients. So these patients then are housed in your emergency department, and so that takes up a bed um, until we can get a bed for them in a psychiatric unit. Homelessness, we have seen our homelessness increase. We don't have a lot of like farmers markets. We have one, but it's limited in a certain amount of time. So I do think that our social determinants of health are some of our barriers here.
sure. Kind of some of the similar that you would face in many communities, but they're just that much like times 10 in terms of difficulty.
Correct.
Transportation for sure. Like, I live in Seattle currently, and I kind of lament having to take the bus sometimes, but at least it's there, it's available. But if you're an OMAC and you need to shoot down to Wenatchee for an appointment and you don't have a car, like you're saying, either one of these two services available for you, or good luck spending the whole day on the bus, getting down there and getting back.
Correct.
Yeah. Yeah, so that's tough. So you also mentioned too, there's like a migrant population and then working with the local native community too. Is there some issue with like language access where people show up needing help, but it's hard to communicate with them?
No. Yes, kind of, sort of. All the hospitals have, and I call it interpreter on a stick,
Hmm.
where you have access to multiple different languages. Those of us that are in these communities, we don't really like to use the computer on a stick just because it feels so informal.
Sure. Hmm.
Um, in Brewster, there's a lot of Spanish speaking nursing assistants, nurses. They have some translators. In OMAC, they have a translator and they have the computer on a stick. Um, and the Native Americans, they all speak English, so that has not caused a barrier. Um, we do have resources that we can use to help mitigate that issue.
Gotcha. Yeah, it kind of goes back to those innovations in healthcare, is just being able to access pretty much any language, at least virtually. Like you're saying, it might not be the most personal way to contact somebody, but you can still figure out communication.
Correct.
Yeah. So you've highlighted some of the critical barriers, challenges, social determinants of health. Were there any experiences during the pandemic that really highlighted those, like made it just front and center that those gaps existed?
Yes. Again, I told you that I became the vaccine coordinator for during COVID. And when the populations opened up for people to be able to get their vaccines, I noticed that we had a large amount of Caucasian people who had money who were the ones that were getting the vaccines, while our migrant population who was out there frontline and doing the work, living in these small cabins, were not coming in. So I wanted to find out why. I took a couple people from my group and we went down and we set up a table right in front of the local IGA. And it was right across the street from one of the apple sheds that we have. And we created forms and we found out most of these patients could not write, they couldn't read. So my group was able to fill out the applications for them to get their vaccine. We gave them on the spot appointments and told them when to come to the hospital to get their vaccine. And we did this throughout that little town. We went to different locations and said, how can we help you? And how can we get you the help that you need? And be able to make sure that everybody was vaccinated appropriately.
Oh, okay. Um, so again, one more time back to provider shortage. Are there some specialties and specific specialties that are getting harder and harder to find in rural areas?
I probably would say providers, nurse practitioners, physician's
Yeah.
assistants,
Mhm.
and doctors. And I think that is harder to get. And That's why I went and got my nurse practitioners because I wanted to be able to also help in this community to provide services for our people.
So it's hard enough to just find providers, let alone like subspecialties within that set of providers, right?
Correct. So we do, all these hospitals do what's called swing bed. And swing bed is a post rehabilitation for patients that use Medicare that can help them with their rehabilitation rather than going to a nursing home.
Mhm.
But in order to have a swing bed program, you have to have physical therapy, you have to have occupational therapy, you have to have speech therapy. And up and down in this valley, there's only one speech therapist. And so we contract, the other hospitals contract to be able to offer that service in all of those locations.
Mhm.
Occupational therapy is another really big one that is hard to find. Physical therapy is usually outsourced, and we contract to try to get the same services amongst all three organizations.
Sure. And you mentioned mental health services difficult. I can't imagine there's a psychiatrist or even a psych nurse up in the OMAC area. Um, or maybe there's more
I
too.
we have counselors, but I think they do have a psychiatrist that comes maybe 1 day a week that can see these patients and prescribe medications.
So they have to commute from probably Wenatchee, nearby community, just to be able to have that service. So
Correct.
I noticed in my notes too, you mentioned obstetrics. And that one seems to be like really critical that there would be access to OB services when you're when you need them. So that must be really tough too.
So all the three, again, just here in this little local, all three of the hospitals used to do OB, labor and delivery. Um, when we started having a shortage of providers, the providers needed to locate themselves in one hospital to be able to provide services. They cannot take call at three different hospitals. And so the two outlier hospitals, Tenasca and Brewster, shut down their OB department. So now patients have to travel to OMAC to get OB services, and they could be living up Aeneas Valley, which could take an hour and a half to come down to OMAC to have OB services. Likewise, those in Brewster, instead of going to their local community, they have to travel 45 minutes to be able to get OB services. So it was really hard when we didn't have enough providers, and we were really stretching our providers in a way that it wasn't helpful for them. So we've now localized that to one area of our county.
Yeah. So yeah, all the like it's we keep talking and come back to this point about these challenges that are maybe not unique to rural communities, but definitely compounded by all of those circumstances. Um, so could we just return to your story a little bit more, just to understand the role of the CNO? CNO stands for Chief Nursing
Chief Nursing Officer.
Officer.
Yeah.
So what's that role like, and what was that like for you?
Um, I wanted to become CNO from a very younger time of my nursing career, and it was because I wanted to make a change. The chief nursing officer is part of administration. They help with budgeting, they help with staffing, they help with education. They really oversee patient care areas to make sure that they're running efficiently, smoothly, and that everybody is in compliance. Um, I loved being the CNO. I absolutely loved it. It felt like I was also giving back, making sure that we were giving the best quality, safest care was one of my utmost um, important factors. Is why I became um, CNO. I mean, like I said, in these rural hospitals, it's a little bit hard. The CNO in OMAC is also a midwife, and so she takes time and has a patient practice, and she's that same in administration and providing the same services that I was in my little rural hospital. She's doing the same thing, but in a little bit. Her hospital is a little bit bigger.
So if you want to learn as much about your profession as possible, be a nurse in a rural community and try to be a CNO in a rural community.
You will be at the top of your scope of practice. I can tell you that.
Nothing will scare you at that point. So I imagine a big part of being a CNO is mentorship of some of the younger nurses and those who haven't been as quite as much experience.
Mentorship, leadership,
Leadership.
providing stability, providing any resources to help. Yes, that is a big part of being a CNO.
Yeah. And so I can confirm that you probably were really good at your job because we have had a chance to collaborate on some projects working with younger nurses. And I noticed that you have a lot of care and compassion when you're working with some newer nurses. So I'm sure
Yeah,
you were fantastic in that role.
thank you.
So we've talked a lot about some of the challenges that are faced in rural medicine. What are some solutions that you can see based on your experiences? How can we continue to improve rural medicine and access to healthcare?
Lots of collaboration. Uh, Having that ability to be able to call Wenatchee Confluence and saying, this is what we have. Do we need to transport, or can you give me some help? And so we have a lot of collaborations amongst all of our organizations, clear to Seattle, Spokane, perinatologist, endocrinologists. We have in Washington State, I think, some of the best collaboration to help keep these patients as close to home as we can.
Yeah, that's fantastic. A number of students that I've worked with, like that's the big thing is people want to be able to receive services in their home communities. So if we can do as much as we can to make that possible, absolutely.
Absolutely.
Yeah. All right. Well, so now we're kind of winding down our time here. You've done a pretty good job of selling me on rural healthcare. So if I were to give you just your elevator pitch to a student who's thinking about going into rural health, what would you say? What would be your best advice you could give to them?
I would say come to rural health. I really feel that this is where I was meant to be. I find that rural health is a specialty all in itself. In those bigger hospitals, you have your specialties of OB, ER, ICU, but I find that rural health is its own specialty. And again, you get to learn so much. You get to collaborate so much. You become a very cohesive team in these environments because we rely heavily on each other and we support one another. It is a great family environment in these little hospitals because again, we rely on each other so much. Um, if you come to rural health, I think that you're going to find a different way to serve patients, and it's very rewarding because they do. You go to the grocery store and they're like, "Hey, there, hi Gretchen, do you remember me?" And it's really nice. Thank you for what you did. Thank you for helping me during this time. And that's how these little communities work. And you see your patients all the time.
Absolutely. Fantastic. And then, of course, just getting to live in rural settings means you get a little bit more connected to nature. And the OMAC area is beautiful, absolutely gorgeous place to live too. So, beautiful settings, beautiful surroundings, as well as getting to work with great people and know your communities. Sounds like a win-win to
Absolutely.
me. So, well, awesome. Well, thank you so much, Gretchen, for your time. I learned quite a bit about what it's like to work in these settings. I did not know some of those things you told me. So I'm excited to hear more about your work. So, of course, as we continue with AHEC, we're encouraging our scholars to think about going into working in rural communities when they graduate. So I'm sure this will be a great benefit for them being able to make those decisions.
I hope so.
Yeah, thanks so much again for your time. And thank you for the students for checking in. We will see you in the next episode.